Next up, we're going to talk about some new advances in pre-hospital care. I'm going to kind of give you a roadmap in the beginning, and then we'll jump into the topic. So first, we're going to talk a little bit about stroke scales. We brought up the topic of endovascular stroke therapy and during the last panel, and we're going to talk a little bit more about how to get the right patients to the comprehensive stroke centers and what scores exist. We're going to talk about pre-hospital TXA and how well that could work in select patient populations. We're going to talk about ketamine, giving that in a pre-hospital settings. We're going to talk about vital signs that may be predictive of trauma interventions like ROBOA or resuscitative thoracotomies. And lastly, I think this is a real interesting part at the end. We're going to talk a little hodgepodge about the utility of end-tidal CO2 for ROSC. We're going to talk about defibrillation pads in STEMI patients and a little bit about COVID. So let's start from the top. We'll start by talking about these pre-hospital stroke scales. How many of you are familiar with what stroke scales they're using in the ambulances on the way to your centers? Any? What stroke scales are they using at your shops that you know of? Yeah? So there's a bunch of them. There's 7 pretty well described ones. There's the LAM score, that's the one that we use in Los Angeles. There's a RACE score, and there's a whole bunch of others. So the next 2 studies basically took a look at all these scores and tried to look at their performance characteristics in predicting large vessel occlusions. Why do we care about large vessel occlusions? We're going to have a whole nother EMA abstract just on endovascular therapy, but 2015 was sort of this inflection point. Before 2015, it wasn't really clear whether or not these endovascular therapies were going to be all that helpful. Hadn't shown like great outcomes in patients that were studied. But as of 2015, randomized study after randomized study after randomized study came out demonstrating the benefit of doing this endovascular therapy in a select patient population. And who is that select patient population? Those are the patients with large vessel occlusions that met other criteria as well, but to even begin the process of being eligible for endovascular therapy, you must have a large vessel occlusion. Now they're studying it in other populations as well, but that's where we know the benefit to be good. And so what these authors are doing in the next 2 papers is to identify, are we able through these stroke scales to be able to figure out who these LVO patients are and subsequently transport them to the comprehensive stroke centers where they're going to be able to get the care that they need through endovascular therapy. So I'm going to give you a little spoiler alert. None of the scores were super highly predictive. In fact, most of the scores missed about half or more of the LVO patients. So let's dive into the literature and then we'll talk about implications for practice. Abstract number 1. Comparison of pre-hospital scales for predicting large anterior vessel occlusion in the ambulance setting, published in JAMA Neurology. This was a multi-center prospective observational trial that went over the course of a year. This was a Dutch study, so happened in the Netherlands. They looked at about 2,000 patients that were possible strokes. Of those 2,000 potential strokes, 8% of those were LVOs. They then applied all of these different pre-hospital stroke scales to see, well, how well did they predict those LVOs? And the best of the bunch was the RACE score, RACE. You see a little chart table in your abstract chapter over there that describes that score. And the sensitivity of that score was 56%. So just a little over, and that was the best of the bunch. Specificity was 90%. So again, in terms of sensitivity, misses about half of the LVOs. Again, the prevalence of LVOs is low, but the ability of these scores to predict them is not fantastic, which is further sort of advanced in the next abstract, abstract number 2. Also very similar to the first one, multi-center prospective trial, also a Dutch study in the Netherlands, about 1,000 suspected strokes. And out of those 1,000 suspected strokes, there was 12% of those were LVOs. And they looked again at the performance characteristics. RACE again performed the best. And the sensitivity this time was a little bit higher, 67%. So it picked up about 2/3 of the LVOs in this case, 87% specificity. So how does this impact us? Unless, if you're an ambulance system and you're trying to come up with a better score, that's a whole line of research there. But what about us in the ED that's receiving these patients? So how many of you work in a comprehensive stroke center? Get a handful, 1, 2, 3, 4, 5, 6. Okay, so a few. So this is pretty emblematic of the broader picture. Most people are not working in comprehensive stroke centers. So if you are working in a comprehensive stroke center, you would expect that the ones that are picked up as LVOs, probably, there's a good chance that those actually are LVOs. There's also a chance that you're going to get transfers from other facilities because some of those LVOs got transferred elsewhere. And if you're in a non-comprehensive stroke center, then your anticipation when you're getting a stroke patient, when the paramedics are telling you, hey, the race score, the LAM score, or whatever was non-predictive for LVO, I would still have my antennas up just to make sure that you're doing your own thorough assessment to see if this patient could benefit from transfer to a comprehensive stroke center. So those are the first two abstracts looking at strokes and the ability to predict those in a pre-hospital setting. We're going to move on to the next clinical question, which is, does tranexamic acid, TXA, perform better in the pre-hospital setting? The reason to ask this question in the first place is so many trials have been done now on TXA, especially in critically ill patients. We've looked at it in GI bleeds, we've looked at it in sick trauma patients, we've looked at it in bad head trauma, and the effect of TXA in those study populations has been either very small or basically non-existent. So in GI bleeds, didn't really show any kind of benefit. Unfortunately, I wish it was a drug that it's easy, but we wish that would have worked. But in trauma patients and in head injured patients, there was some signals of benefit. And so we'll talk about both the trials that were done in the ED showing benefit, and then we're going to talk about their sort of pre-hospital counterpart studies to see if those worked. With, again, the rationale being that even in those big ED studies, with TXA, oftentimes what people are saying are the TXA proponents will often say, well, if you just give it early enough, it should work better. So what could be more early than pre-hospital? So let's see if it works in the pre-hospital setting. Abstract number 3. This is the STAMP trial. Tranexamic acid during pre-hospital transport in patients at risk for hemorrhage after injury, a double-blind, placebo-controlled randomized clinical trial. This is basically an extension of the CRASH-2 trial. If any of you remember what the CRASH-2 trial was, this was a multi-center, multinational, huge study on very, very sick, critically ill trauma patients. And what they did in that study was they gave TXA early on, and they looked to see if there was any impact on mortality. And what they found was that there was about a 1.6% or 1.5% difference in absolute mortality. And there were many, I can't even remember the absolute number of patients they enrolled, but it was very impressive. And with that absolute number, the number needed to treat in sick, ill trauma patients that were hypotensive, it took about 65 or so patients getting TXA before one benefited. So again, even though there was a benefit, it took a lot of trauma patients to give TXA to before you found that benefit. Now, the STAMP trial was done in Pittsburgh. This was a randomized controlled trial as well, 2015 to 2019. They enrolled trauma patients who had heart rates greater than 110, so tachycardic, signs of potential hemodynamic instability, or systolic blood pressures less than 90, so with trauma at 4 level 1 trauma centers. They randomized them to getting TXA or no TXA, and then they looked at 30-day all-cause mortality. It's interesting what they found. Statistically, they found no difference. The TXA group had an 8.1% 30-day all-cause mortality, while the no TXA group had a 9.7% all-cause mortality. Again, an absolute difference of almost the exact same as they found in CRASH-2, 1.6%. However, they didn't power this study the way that CRASH-2 was, so they didn't find any statistical difference. But signal of potential benefit, but it is actually a negative trial. So the conclusion shouldn't be that we're giving TXA as a bolus in the pre-hospital setting. It's okay for these patients to come to the ED and they can get TXA there. My other plug for TXA, anybody work in a trauma center? We got a couple, and on this side, okay, good. So we got some trauma center. In trauma, in the setting of trauma, our trauma surgeons are just fine with us giving TXA. They're totally cool with it. What they're not fine with is prioritizing TXA over all the other things that save trauma patients' lives. If they need blood, if they need a level 1, like a transfusion, the level 1 transfuser, like rapid infusions and all the other things that they need, rapid imaging, getting them to the OR and all that, do not delay that stuff for TXA. But giving TXA, if you are going to give it less than 3 hours, 1 out of 65 or so patients may benefit, we think. All right, next up, abstract number 4. Now we're going to talk about TXA in head-injured patients and trauma patients. This abstract is called The Effect of Out-of-Hospital Tranexamic Acid versus Placebo on 6-month functional neurologic outcomes in patients with moderate or severe traumatic brain injury. This was done in JAMA 2020. This is the sister trial to the CRASH-3 trial. CRASH-2 was sick trauma patients. CRASH-3 was in head-injured patients with bleeds to see if giving TXA would help those patients. So in the CRASH-3 trial, what they found was that in patients with GCSs of 12 to 15, in those patients, there was signals of benefit, but their initial primary outcomes of all-cause mortality in the CRASH-3 trial, that was all negative. So it was actually, in fact, a negative trial based on its primary outcome. Then they did some subgroup analyses of these patients who had moderate head injury, GCS 12 through 15, with positive head CTs. And in those patients, there was a benefit. And so they described that benefit. So some kind of look at CRASH-3 and say, well, it was a positive trial. Other people will look at, the purists of the literature will say it was a negative trial. But potentially it could help in the moderately injured patients. So let's see how it performed in the pre-hospital setting. This was an RCT, double-blind, placebo-controlled in about 1,000 TBI patients. They enrolled all patients with moderate severe GCS 3 through 12 who weren't hypotensive, that didn't have other traumatic injuries to try to localize it and keep the study population focused on traumatic brain injury. And then they looked at favorable neurologic outcomes based on some score called the GOSE score. And they looked at it in the TXA group and the non-TXA group. What did they find? They found a 65% rate of favorable neurologic outcome in TXA, 62% in placebo. Again, no statistical difference. So taking all this pre-hospital literature together, both of these trials, both the CRASH-2 equivalent and the CRASH-3 equivalent, didn't really have any statistical significance. And sort of it kind of takes us back to, well, TXA, as much as we wished it would work, it's such a simple intervention, sort of a low-risk intervention. As much as we wished it would have worked, it doesn't seem to work, at least in these trials in the pre-hospital setting, and if it does, it's in such a small number of patients that it's not finding statistically significant signals. And I think there's a lot of variability. I don't know if you're in your trauma centers for head-injured patients with bleeds, if they're giving TXA. In ours, generally, we're not. For trauma patients, we are, but it's not being prioritized. So interesting stuff for TXA. And then there's a whole we could do a whole EMA chapter on the TXA for nosebleeds and vaginal bleeding and all kinds of other stuff. But we're going to try to stay focused here. All right. Question number 3, is ketamine safe to be used pre-hospitally? How many of you are using ketamine in the ED for either acute agitation or for pain? Keep your hand up if you like ketamine and you think it's a good drug for it. We got a little mixed bag over here. A lot of folks I talk to, at least in our shop, it's one of those, like if I only had a few drugs in my armamentarium, like ketamine would be one of those. And so there's a question, there was, after the George Floyd case, they talk about in this chapter where ketamine was given, and obviously there was a terrible outcome in that case. This whole concept of excited delirium, should we be giving ketamine in the pre-hospital setting for excited delirium? And is it safe? What are the adverse events and whatnot? We need to really be careful and judicious about the way that we use ketamine. I agree. I think it is a wonderful drug. I think that it has some caveats and needs to be done and given in a responsible way. So abstract number 5 starts to dive into this question. Before I get into abstract number 5, let's talk about like the studies that are in the ED before we get into pre-hospital. There was a recent Canadian study that looked at the impact of giving ketamine versus giving Haldol and Versed in agitated patients. And it seemed to have equivalent safety and a faster onset of action when given IM, sort of the 4 milligram per kilogram IM dose. Again, single center, but it was an RCT. And then there's other papers that have looked at this and found ketamine to be pretty safe in the ED setting. So let's see how it performs in the pre-hospital setting. Abstract number 5. Out-of-hospital ketamine indications for use, patient outcomes and associated mortality. This was in the Annals of Emergency Medicine 2021, so very recent. So this is a database review from the Texas EMS database, and they looked at 11,000 cases of ketamine that was administered over the course of 1 year. It's a lot, 11,000 cases where ketamine was given IM, but Texas is a big state. They were able to link about 2,000 of those records to the ED records. And then they looked at like what types of patients were getting them. It turns out about half of them were because of trauma or pain that they got the ketamine. 35% were due to altered mental status or behavioral issues. And then they looked at like, well, how many patients died as a result of this, or died in general, and how many were associated with ketamine. So there were 8 on-scene deaths in these 11,000 cases of ketamine, and there were 120 hospital deaths. They found that maybe 2 of these cases, the on-scene deaths, could have been attributable to the ketamine, possibly. They found that of the 11,000 cases, 8% were associated with hypoxia, 17% associated with hypercapnia. Interesting. Well, and if you think about somebody who's agitated delirium or may have drugs on board or whatnot, what if we gave them Versed? What if we gave them something else? Would there be a similar rate of hypoxia, hypercapnia? My guess is probably. It's just not, shown in this study. This is a ketamine-only evaluation. But there was a subset of patients that got hypoxia and got hypercapnia. The conclusion of this study by the authors was that, ketamine is relatively safe but can be associated with some respiratory issues. So it's not a free shot. You're not just going to be able to give everybody 4 milligrams per kilogram of IM ketamine and expect that everything's going to be okay every single time. In fact, about a fifth of the time, you should anticipate that there's some respiratory issues associated with it. Now, I can tell you in our ED setting, and many of you have probably experienced something similar, like a patient with, say, COPD, say a patient that already has some respiratory issues, and then you give that patient ketamine for whatever reason, procedural sedation or whatever you want to give it for. Those patients tend to drop their sats, tend to have respiratory depression at a far higher rate than patients that are completely healthy. I often think about when I see somebody who's hypercapnic or hypoxemic, that in and of itself to me is a drug. If you give ketamine and then you give Versed, like you'd expect a bigger drop in respiratory depression. For me, if somebody already has baseline hypoxia or hypercapnia or whatnot, and then you throw the ketamine on top, expect and anticipate that that patient is going to have more chance of respiratory depression. Now, giving ketamine also it's unclear if it caused the hypercapnia or hypoxia, or did that patient also have another medication on board already? Was there maybe an opiate on board? Was there some other drug on board that caused it? We don't know. But we do know that just giving ketamine can cause respiratory problems. Abstract number 6, far smaller study than the Texas study. This was out of Australia, 358 cases of pre-hospital ketamine. In this study, they found that hypoxia was associated in 5% of cases, emergence reaction 0.8% of the time, and patients got intubated 0.6% of the time. That was all pre-hospital. Once the patient arrived to the ED, however, in the patients that got ketamine, about 15% of those patients got intubated. Okay? This is all very descriptive. All these papers are just descriptive. Abstract number 7, another Australian study, even smaller, 105 patients. Out of those 105 patients that got IM ketamine in the field, about 38% of them had adverse events. It's pretty high. They found that it was 98% effective in controlling agitation or controlling pain, or the reason that they gave it. Oh, actually, in this one, it was all behavioral, excuse me. It was 98% effective in this case. But it led to 14% rate of oversedation, 15% rate of obstructed airway, and 15% rate of ET tubes. Again, so in these behavioral agitated patients, we can give ketamine for scene safety, for patient safety, for provider safety. Ketamine is wonderful. Just be really, really careful after you give it to be prepared for the next 2 or 3 steps, because there is a significant number of these patients that will have potential respiratory problems that may need to be intervened on, anywhere from just putting on oxygen or jaw thrust or controlling their laryngospasm to full-on intubation. Okay, so ketamine serves a purpose, and it's great, but it has its issues, and we got to be mindful of it. Is anybody from Canada here? No? Ken is. Oh, there we go. I just asked if anyone's from Canada, and you just walked right in. On the ski slopes in. So in Canada, if you go to the ski slopes, you go to Whistler or something like that, if you break an arm on the slopes, the medics on the slopes actually carry little sticks of ketamine. You don't see that here in the States. Say it again, and maple syrup. It's the, what is it, the sucrose that they give for kids. It works the same on the, yeah. That's right. Sweeties. So, you know, ketamine has like a broad scope of use, and again, wonderful drug, just be careful. Next up, we have question number 4, which is, can the need for thoracotomy be predicted based on pre-hospital vital signs? Again, this is speaking mostly to the trauma folks. The abstract number 9 comes out of Maryland, the Shock Trauma Center, where they wear the pink scrubs. And abstracts number 9 and 10 actually came out of LA County, USC. All three of them, the bottom line for all three is that if you look at the pre-hospital vital signs, you often can predict that the patient would have decompensated and may need intervention in the form of resuscitated thoracotomy or a REBOA. Okay, so we'll dive in a little bit to each of these. Abstract number 9, that was the Maryland study. This was, I don't want to spend too much time on this one. They basically created a very complicated continuous vital sign monitoring system that was called the BRI, or the Bleeding Risk Index. And then they looked at that score and they said, well, in patients that had higher BRIs, were they at higher risk for getting thoracotomized or REBOAs and whatnot? And the answer was yes. And it was pretty well aligned with the vital signs that they monitored in the ED. So the conclusion is, if you look at the pre-hospital vital signs, it can be very telling, just as your vital signs in the ED would be. The next two abstracts, abstract number 10, where is this abstract number 10? Who would have benefited from the pre-hospital use of resuscitated endovascular balloon occlusion of the aorta, the REBOA? This was an autopsy study done at LA County, USC, October 2019. Basically, this was a retrospective observational study, and they went back and looked at all the autopsy records for about 200 traumatic arrest patients that came in from 2014 to 2018. They looked at those patients and they said, well, in the absence of, like, say this patient didn't have any head trauma and they had fatal sort of pelvic and abdominal injuries, those were deemed to be candidates for REBOA and they looked at those patients and they said, well, could we have identified these patients based off their pre-hospital vital signs? And they kind of matched that to their EMS records. And they found that the strongest predictors of patients that had abdominal or pelvic trauma that would have been amenable to REBOA were if they had a GCS greater than 8, so lack of significant head trauma, and a SAT of greater than 90%, and a systolic blood pressure less than 90%. So if you looked at those vital signs, that could have helped predict patients that may have needed REBOA. Fine. The next abstract talks about something that I think is super important, whether you're at a trauma center or not, which is pre-hospital narrow pulse pressure predicts need for resuscitative thoracotomy and emergent intervention after trauma. This was published by one of our trauma colleagues, Morgan Schellenberg, who works on our trauma team, wonderful person, who looked at the presence of narrow pulse pressure in the pre-hospital setting. What is narrow pulse pressure? They defined it in this study as a delta between your systolic blood pressure and your diastolic pressure of less than 30. And they looked at a trauma registry over 13 years, and they looked at patients that ended up having arrest and resuscitative thoracotomy, mortality, emergent interventions, things like that. And in the patients that had narrow pulse pressures in the field or in the ED, they found that there was a 5% mortality in those patients, compared to normotensive patients who only had a 1.8% mortality. Hypotensive patients obviously had a far higher mortality. They had 12% mortality. So I think we're all great at looking at the low blood pressure. You know, blood pressure, the patient has a pressure of 80/40. Of course, you think that the patient's mortality could be much higher. But in those narrow pulse pressures, we see this so often in our traumas. You get your multi-system blunt trauma from a rollover MVA, and they're sitting there on the monitor with a blood pressure of 120/100, and everyone's like, oh, okay, good. They have a good blood pressure. That is not a good blood pressure. That is a precursor to a lot of potential badness. So just paying attention to that narrow pulse pressure can be really important. And finally, we're going to do our hodgepodge section here. So let's go to abstract number 11. This is the association between end-tidal CO2 and return of spontaneous circulation after out-of-hospital cardiac arrest with pulseless electrical activity. So this was another Ontario study it was a chart review. They looked at patients that had out-of-hospital cardiac arrest. 208 of those patients had PEAs. And the primary outcome that they looked at was return of spontaneous circulation. Then they looked at what levels of end-tidal CO2 or increases in end-tidal CO2 were predictive or associated with ROSC. And they found that patients that had a delta in their end-tidal CO2, for example, if they started with an end-tidal CO2 of 12 and they had a delta of 20, like up to 32 or greater, those patients had a far higher association with getting return of spontaneous circulation with a 95% specificity. So I don't know how often you guys are getting on the base calls or whatnot and you're hearing like what's going on in the ambulance, but we know from old data, like old 1990s data from the New England Journal, that a end-tidal CO2 less than 10 at about 20 minutes of resuscitation has a very low association with survival. Right? Like those patients don't do well. So you can call that in the field, usually doesn't need to be transported. But if you start and you get a greater than 20 delta increase in your end-tidal CO2, that is highly predictive, and most of those patients can do well, at least in terms of ROSC. We don't know what their neurologic outcomes are. So it's interesting. Next up on the hodgepodge section is abstract number 12, decreasing time to first shock. Routine application of defibrillation pads in the pre-hospital system. This, again, we're going back to Ontario research. They looked at 446 STEMI patients in the pre-hospital setting. And they did something interesting. For 2 years, they did not routinely put on defibrillation pads in all their patients, their STEMI patients. And then they made an intervention. For 2 years, they put a defibrillation pad on all their STEMI patients. And what they found was, in the time before they implemented this intervention, 7 patients had STEMI with VFib VTAC that required defibrillation. Of those 7 patients, it took about an average of 73 seconds time to defibrillation. They then converted to putting defibrillation pads as a matter of routine on their STEMI patients. In the 2-year post intervention, those patients, there was only 4 of them, but it was 18 seconds from time to defibrillation in those patients. And now there's no patient-oriented outcome in terms of like, was their mortality better, et cetera, but we know and can probably extrapolate that time to defibrillation does make a difference. We know that earlier CPR, earlier defibrillation probably works, so we can't say with 100% certainty, but this intervention seems to have made a difference in a small subset of STEMI patients. I'll finish the last one and I'll roll over for the question. And then the last 2 papers are basically, a reminder of how difficult a time COVID was in terms of out-of-hospital cardiac arrests, and something that all of us have experienced in the ED setting. Abstract number 13 and abstract number 14. Abstract number 13 just kind of reviews the incidence, the number of patients that suffered from out-of-hospital cardiac arrest. This was done in New York. They looked at a period of March and April in 2019 pre-COVID, then they looked at April 2020 during COVID, and there was 1,400 out-of-hospital cardiac arrests during that time, pre-COVID. That same time period during COVID, 4,000 out-of-hospital cardiac arrests, 3 times the range, tended to happen more often in elderly patients, non-white patients, and patients with comorbidities. The impact was big. And finally, the last paper was a Polish systematic review that looked at how poorly these patients did. And it turns out that the patients not only had more out-of-hospital cardiac arrest, but they also did more poorly. Less ROSC, less discharge, less patients made it to hospital discharge, and less did well with their neuro outcomes. So more patients, more death, poorer outcomes.